Hi and welcome to talking through CPR with me. I'm Holly Witchell and I'm one of the ICU nurses here at Langford Vets. So we'll cover through basic life support, advanced life support, and we'll cover over the key points that have been updated in the new recover guidelines as well. So our key points we're going to cover in this talk today are prevention. So we want to know sort of how we can prevent our patients from going arresting. Obviously, this is not possible all the time, but being prepared is really key to team dynamics and being efficient as possible, and maybe assigning roles prior to our patient going to arrest. And we'll go through basic life support and advanced life support. The type of equipment we need in our sort of crash trolley or crash box. Again, we're very lucky here. I have a big ICU with a crash trolley here, but not everywhere has that. So even adapting it to your sort of side of your clinic, it was absolutely fine. And talking about sort of teamwork, training is really important. So teamwork is the key, and training our teams on a regular basis really does impact the outcome of CPR. So it's really important. And talking a little bit about post-CPR care. So post-CPR care will be updated in, I think, 2027. Part of the Recover Initiative, we're doing a massive review. This was initially created in 2012, and it's only been sort of updated in the last sort of year or so. And we'll go over those updates today. So the goals of CPR, so we really want to try and perfuse our, sort of basically we're perfusing the whole body with our chest compression. So really key is that we are perfusing the heart, lungs, and then hopefully that'll go to our other cells as well. But our ventilation, like ventilating our patient, getting oxygen delivered through our perfusion, like those chest compressions. Okay, so basic life support is really important here. If we're not doing basic life support properly, we're not going to have a good outcome for our patient. So we really want to get a return of spontaneous circulation, which is ROSC. So we'll talk later in the slides of what this will look like and how we want to achieve this. But basic life support is the key to achieving a good outcome for our patient. But again, these patients usually got something systemically unwell with them, so we're not always going to have a high success rate with CPR. So that's something also to bear in mind as well. So who's at risk? So as I said, patients with systemic disease. So for example, like septic patients, cases who've had like big polytraumas, maybe they've lost a lot of blood, and they've got like reperfusion injuries, like crush injuries. Sometimes these can be like accidents within the hospital, so iatrogenic things like we're given an overdose of anaesthesia through a volatile agent, or perhaps drug therapies, which obviously we can reverse those. And again, if we've got patients who are in respiratory distress, so thinking about those patients who may be brachycephalic and they're having a really hard time, they're really hyperventilating, and they're really struggling, their airways quite swollen, or some cases if they have aspirated, or those cases where they might be fatiguing as well. So all those sort of patients we've noticed maybe they're fatiguing, perhaps we maybe need to put them on the ventilator, but they've gone to respiratory rest before the ventilator, or perhaps they are part of our brachycephalic friends. We have had cases before where they have had sort of neuromuscular problems and have been eating and they've basically choked on their food. So again, those sort of cases, again, having a good think of why this patient's in your care and what's going on with them, and are they at risk of going to a cardiac or respiratory arrest. And interestingly, on the Recover Guidelines update, they've said like cats have higher survival rates. This is due to their having a smaller thorax, so obviously they're much more easier to compress their chest and get a better perfusion in these patients. So you've got a 35 to 55% chance of getting return of spontaneous circulation in these cases. And that's just in general for cats and dogs, and a 6 to 9% survival to discharge as well. So again, those are quite sort of low survival to discharge rates, and that's something to bear in mind when carrying out CPR. And I think they really focus on team dynamics and team training, because obviously the outcomes of CPR aren't really high. We're not always going to get our patients back, especially if they have got, a disease we cannot sort of fix in these patients. So really key to bear that in mind, especially if you feel like you've not achieved a sort of a good team dynamic, and remember that actually the survival to discharge is very low. And yeah, being prepared, and we want to prevent these patients. So I think, again, we sort of briefly touched on the previous slide, sort of awareness, which patient in our sort of nursing area are we worried about? Have we flagged it to our other team members? Have we let the veterinary surgeon know? Have we got a code on this patient? So I think it's really important, are they a resuscitate? Are they a do not resuscitate? Are they sort of closed CPR or open CPR? So obviously closed CPR, we do external chest compressions, and open CPR is where we will crack the chest open, get our rib retractors out, and we'll put sterile gloves on and do cardiac massage to that patient. So again, it's like how far are those owners willing to go, and what's in the best interest as a veterinary team? Can we give to that owner the information of whether is it in the patient's best interest to do CPR open closed, or are they best to be a DNR? Because obviously we get some patients who are really sick, and with this help their sort of quality of life would be sort of a welfare thing we look at as well. And again, we want to make sure these patients have got monitoring on them, that the ones we're really worried about. So we can easily see this patient. So if we have a separate cat ward, perhaps we would maybe bring that cat into the area where there is more staff. Perhaps they're not going to be, perhaps they will be in with maybe some canine patients, but that's the benefit of the patient. If they're quite critical, they may not be aware of their surroundings as much, and it's really important, imperative that we see those patients and we're able to keep an eye on their mentation and visualize them, so we can see their respiratory effort pattern very easily, and changes in behavior and mentation. Popping an ECG on these patients, really important if you have one. So again, most patients obviously have a multi-parameter monitor, but again, we want to be checking those vital signs constantly if we can, and obviously having an ECG monitor on them makes it a lot easier. And again, things like checking blood pressure, cylindrical with an oscillometric would be very helpful. Sometimes if they're really critical, that's not always the case and you can't get an accurate oscillometric. But again, we want to be checking those vital signs fairly frequently, and preparing the team of this patient, or I'm not really happy, this patient looks like it might arrest shortly, or I've popped the ECG on this patient because I'm not happy, and I've increased its monitoring to every 20 to 30 minutes, as well as obviously liaising with your veterinary surgeon as well to make sure as a team we're all together on board. So here we have a little snapshot of a crash there. So we've got a patient, they've crashed. What are we going to do next? So our patient's arrested. As you saw in that little quick video, obviously we're very lucky we have a crash table, but you can start CPR on the floor. They do not have to be on a special table or anything like that. A flat surface will do. So following the algorithm from the new guidelines, we're going to get that patient out. We're going to shake and shout. So we're not going to feel for pulses. There is no time. So as soon as you start CPR on a patient, they'll let you know whether they're alive or not. So I've had cases where we've started chest compressions, this patient like he was about to arrest. It sort of keeled over, we started chest compressions, and actually that it wasn't fully dead. So if you're shaking, pulling this patient out saying crash, we're going to start chest compressions. If the patient's not fully arrested or isn't arrested, they'll let you know very, very quickly. But again, we're best to start chest compressions as soon as possible. So we'll pull that patient out, shout for help. If you have a crash alarm, pull it, ask someone to go, if you've got an animal care assistant, student, any other person to run and go get help for you and to get more people. So we're starting chest compressions. We're going to make sure that our airway is clear. So obviously the patient could have gone to respiratory arrest, it could have regurgitated. So if we have got suction nearby, we want to clear out that excess, either sort of regurg, food in the airway. And again, we want to intubate that patient. So we're not going to stop chest compressions for intubation. We're going to intubate those patients in lateral recumbency. And it is easier to intubate patients that have arrested, but again, if people don't feel confident in intubating in lateral recumbency, I recommend doing it as part of your normal routine, like neuterings and intubating patients that way, just so the team feel more confident. Again, better outcomes for the patient and better team feeling about CPR the more training you do in these situations, or prepare for these situations. So we've got somebody starting chest compressions, we've pulled the patient out, we're either on the crash trolley or we've got her on the floor starting CPR, and we've hopefully got access into our patient's airway. And we'll hope to have more people come running as we've asked for help, pulled the crash alarm, and we want to have somebody who is timing and recording. So ideally we'd have somebody in who's going to run the crash. They say, I'm going to run the crash today, and they assign these roles of like compressor, ventilator, recorder, drug administrator. But sometimes initially that might not happen, and you might have to then just, the person who's found the patient, start chest compressions and get the airway access. And obviously once we've started that 2-minute cycle of basic life support, where it's chest compressions and ventilation, we can then go on to advanced life support. So this all happens very quickly at the same time, basically. So we're not going to suddenly just wait till we've done 2 minutes of basic life support and then start advanced life support. It's all going to happen at the same time, and the importance of making sure we do 2-minute cycles of chest compressions, ventilation, and the person recording this on the timer and writing information down, they will record once we've been doing 2 minutes, and let the person who's leading the crash know, or the team know. And as we're doing these chest compressions and ventilation, we're going to be adding on advanced life support. So advanced life support is where we're placing ECG pads, capnography, any drug therapies, and defibrillation. And in the new update, as I said, we're not looking at checking for a pulse. We're going to pull this patient out and start chest compression straight away. And obviously as we're pulling them out, that is sort of like a shake and a shout, isn't it? Like crash, pull this patient out, and we'll start chest compressions. And really important to note, 1 minute of chest compressions takes us to reach optimum blood flow in the patient that we're doing CPR on. So ideally you want to get to 2 minutes, but again, this is quite hard, and doing 2 minutes of chest compressions is really tough. So, I mean, I definitely aim for 1 minute, and try and get to 2. But again, if you notice your chest compressions aren't sufficient or you're getting tired, we always need to try and swap out. So again, keep bearing in mind, we want to get to 1 minute of chest compressions, but ideally we want to continue that with no break for 2 minutes. But I think, again, it's very difficult sometimes to maintain those chest compressions for 2 whole minutes. But if you bear in mind the 1 minute of compressions to reach optimal blood flow is important. And again, we're going to repeat this 2-minute cycle. So I'll go on the other slides and we'll talk about what we do. But basically, we're going to do 2 minutes of chest compressions, ventilation. We'll have attached our ECG pads, capnograph, and we'll have somebody recording this down, as well as somebody feeling for a pulse. So obviously, a pulse is a very crude way of feeling for how good our chest compressions are. But another way that we want to quantify it more appropriately and evidence-based is via our capnography. So we want to make sure we've got our capnograph. That's the most important piece of equipment in CPR, with your capnograph, and using it alongside somebody feeling for a pulse. So we'll repeat this cycle every 2 minutes, and once we have done 2 minutes of CPR, we pause and stop, and we look at our ECG and we decide whether we're in a shock or non-shock rhythm, and we'll talk about that on the next few slides. Another really important part of team training in CPR is closed loop communication. So this is where we basically, this all happens at the same time during CPR. We've asked maybe someone to intubate. So we want to basically say, patient's intubated, can we tie the tube in? Yes, tube is being tied in. So I think sometimes as veterinary staff, we just get given an order, especially nurses, get given an instruction and we carry it out, but we actually need to follow that back up, and we just say we've done what we've been asked to do, and that's closed loop communication. So we want to make sure that everybody in the team knows that, you know, someone's tied that tube in, somebody's given that adrenaline we've asked them to give, and, you know, I think it really helps the person recording it, the person leading the crash, and also the other people involved in the crash. So everybody has a role to play, and everybody needs to know exactly what's going on with this patient.